Welcome to the class. So today we'll be talking about medicine in the first session. So as you all know, medicine is a vast subject. Covering it in 2.5 hours or 3 hours is really challenging. So if we will try to catch up with all the clinical points, even 2 or 3 days won't be enough. So as much as possible, we'll constrain our talk regarding what exactly is needed for your exam. So what are we going to do now is we are going to see all the systems in the medicine, and we are going to see what exactly the words you are going to look for in the MCQ to get the correct answer. So if we read in that way, medicine would be more fun, I guess. For a short review, that's how it should go. So the first topic is about the nerves, the nervous system, and then the second topic is going to be the cardiovascular system. So these two topics, if a student sit in these two topics, actually they consume a lot of time in these two topics, and they find it difficult to move away from this topic and deviate to other topics. But you need to know that medicine has a lot of small topics also. Those small topics are very essential also. So hematology is an example. Renal system, hematology, there are some examples where you can study in a limited way, but you can score more. So we are going to see everything today. So, but anyway, to start with, starting medicine with neurology would be very optimum. So here we are. Shall we start? Am I audible enough? Okay. So the first, the first topic in neurology is going to be neuralgia. Neuralgia. Neuralgia means pain in the nerves. Pain in the nerves. Nerves, algia is pain. Neuralgia, nerve pain. So there are a lot of types of neuralgia, but for FMG aspect, we consider these 4 types of neuralgia: trigeminal, glossopharyngeal, geniculate neuralgia, and Sladder's neuralgia, out of which trigeminal and glossopharyngeal are most important for your examination. So we are going to see the key aspects in them. So trigeminal neuralgia, first I'll read out the point quickly. So trigeminal neuralgia um, is a cranial nerve 5 problem. Trigeminal neuralgia is cranial nerve 5 problem. So the patient will have pain in either lips, gums, cheek, or chin. So there is a place, or in ophthalmic division. So wherever there is a distribution of cranial nerve 5, we are going to have the pain. So the pain will last for a few seconds to a minute. It can occur spontaneously with or with movement when the patient is doing any speaking, chewing, smiling, and most of the time the treatment is going to be carbamazepine. So for trigeminal neuralgia, for your MCQ purpose, you need to remember 3 important points. The first important point is it is cranial nerve 5 problem. The second important point is when the patient speaks, chews, or smile. So speak, chew, smile. So SCS, you need to remember that when speaks, chew, or smile, the patient is or when he moves his head, is going to have a pain, and the treatment is carbamazepine. So these 3 points are highly important for your trigeminal neuralgia. So if you know this, you should be able to crack the MCQ. Okay, so the type of pain that would be described in your examination is going to be excruciating pain. Excruciating pain. Okay. Okay. Next is glossopharyngeal neuralgia. Glossopharyngeal neuralgia is cranial nerve 9 problem. Glossopharyngeal neuralgia is cranial nerve 9 problem. Sometimes it can be cranial nerve 10, but for your MCQ, don't follow that. Go for cranial nerve 9. So the pain is going to be starting in one side of the throat, unilateral throat, or near the tonsil, palate near the tonsil of fossa. So tonsillar fossa. So one side of the throat or one side of the tonsil. So tonsillar fossa. So swallowing or coughing can cause pain. So as I said, if you go for trigeminal versus glossopharyngeal, the major differentiation here is speaking, chewing, smiling causes trigeminal neuralgia. Swallowing and coughing causes glossopharyngeal neuralgia. So this word is important. So both of them has almost similar drug of choice. That is going to be carbamazepine. So I don't know if you'll get carbamazepine in your MCQ, but you need to know this point. Speaking, chewing, smiling for trigeminal neuralgia with the cranial nerve 5 problem. Swallowing or coughing is going to cause in pain in glossopharyngeal neuralgia. So where's going to be the pain? The pain in trigeminal neuralgia is going to be in the trigeminal area. So lips, gums, cheeks, chin, and ophthalmic division. Whereas in glossopharyngeal, it's going to be in the throat, that too, especially in one side of the throat. So I want to make a picture of a person. His mouth is wide open. So here I write 9. So I write 9. So this place you need to remember as 9 because it's cranial nerve 9 problem. So you need to remember glossopharyngeal neuralgia is one side of throat problem. Whereas trigeminal neuralgia, you should know the pain could be anywhere. It could be in the gums, cheek, chin, anywhere in the ophthalmic division. So everywhere like this. But one side of throat, it's going to be glossopharyngeal neuralgia. Okay. So both of them carbamazepine. Next is geniculate neuralgia. Geniculate neuralgia, you need to remember ear. Geniculate neuralgia, you have to remember ear. Pain is in the ear. Okay, next is Slader's neuralgia. Slader's neuralgia means pain will start. Sorry, yeah. So the pain will start from the nasal bridge, and it will radiate to the forehead. This is how the pain will be. So this is Slader's neuralgia. Okay. So if you don't remember geniculate or Slader's neuralgia, that's still fine. But you need to remember the first two. So I repeat, the most important. So as much as possible, I said we will revise. So trigeminal neuralgia, you need to remember cranial nerve 5 problem. You need to remember when the patient, I can say chew. When the patient chews food, this is what you will get in your MCQ most probably. Chewing food. Next is glossopharyngeal neuralgia. It's cranial nerve 9 problem. Patient is going to get pain when he swallows. So chewing, when person chews, he's getting pain, it's trigeminal. When a person swallows the food, he's getting pain, it is glossopharyngeal. Whereas in trigeminal, we already saw in lips, gums, cheek, and chin. Whereas in glossopharyngeal, the pain is going to be in the one side of throat. So unilateral throat. I hope I'm clear in this topic. Now, next is most common involvement of cranial nerve. This is what is given in your QRS. So you would have seen, you would have completed anatomy, a lot of points that you would have seen in cranial nerves. So I did not put those points here. So all I try to make is some important points from those here. So out of which in medicine, 2 points that you need to know is what nerve, cranial nerve is involved in leprosy, that is facial. What is involved in herpes zoster, that is trigeminal nerve. So as far as medicine is concerned, only these 2 points are essential in cranial nerves. But these are all anatomical points which I don't want you to miss out, so I repeated it here. So smallest cranial nerve is going to be trochlea, longest cranial nerve is going to be vagus, largest is going to be trigeminal, cranial nerve involved in raised intracranial pressure is going to be abducens, and cranial nerve with longest intraosseous course. So this is longest cranial nerve which is extraosseous, vagus. So intraosseous is going to be, that is within the bone, that's going to be facial. So intraosseous bone is going to be facial. So as long as medicine is concerned, if you remember the first two, that should be fine enough. So I repeat, leprosy is facial, herpes is trigeminal. If you remember these 2 points, your exam should go smooth. Leprosy, facial nerve, herpes, Hepatozoster trigeminal nerve. Okay. Next, hemorrhage in CNS. So I have mentioned two types of hemorrhages here. One is subarachnoid hemorrhage, another is intracerebral hemorrhage. So before going there, I'd like to show this picture. So these are the different types of brain hemorrhage that is going to happen in a person who's meeting a cerebral injury, who's meeting an injury. So the patient could have a hematoma that is outside, that could be epidural outside the dura mater. So this is how it is, or subdural within the dura mater, subdural, or within the parenchyma, there's going to be intracerebral bleed, or in the subarachnoid space, subarachnoid bleed. So these four places, these are very, very essential, out of which the many patients with comorbids of hypertension, uncontrolled hypertension, are going to end up with having intracerebral hemorrhage. So as long as aging is concerned, you get a patient with older age and you get a patient with chronic long-standing hypertension or malignant hypertension, you are going to direct your MCQ towards this intracerebral hemorrhage. So these three things, epidural, subarachnoid, and subdural, if you're seeing, so in these three, epidural and subdural, so these two should be concerned to trauma. These two should be considered trauma, out of which subdural is the word that you're going to focus in your MCQ is going to be fall. Subdural means you're going to focus on the MCQ, a patient, elderly patient who falls. So why I'm telling this right now, because the age, the higher age is given for both subdural and so the elderly age, for example, 80 years or 70 years, is given for both subdural and also intracerebral hemorrhage. So what you're going to check for is the hypertension. If the patient had a history of hypertension, chronic hypertension, and BP is very high, you are going to direct your answer for intracerebral hemorrhage. But if the history talks about fall, so most probably they won't use the word fall. They might say the patient is a known case of Parkinson. He was identified to be in the floor, unconscious. So he was taken to the hospital, and MRI brain was done, which shows, they will show a picture. So you're going to say it is subdural, because Parkinson's patients are tend to fall a lot. Okay, so Parkinson means there's going to be a lot of fall. So that's what they're going to direct. Whereas if you look here, epidural and subarachnoid. Now, subarachnoid is a different case, but epidural and subarachnoid, epidural, I would like to mention here, epidural can be a trauma or a fall, actually, a fall from height, but your MCQ will not focus on the fall, your MCQ will focus on trauma. So trauma is epidural. So what happens in epidural is this area of bleeding is going to increase, keep on increasing, and then this is going to push the brain parenchyma to the other side. So what is going to happen is patient will transiently lose his consciousness and again regain his consciousness. That is going to be called as lucid interval. Lucid interval. So they'll be talking about this lucid interval in a younger person who met with a trauma. For example, a two-wheeler skid and fall or two-wheeler accident. Most probably they will be given a two-wheeler accident. So two-wheeler accident, patient, young patient who comes to your hospital with a lucid interval. So you're going to answer the patient for epidural hematoma no matter what. So this is a simplified MCQ. Okay. Okay. So subarachnoid we'll see. So as long as we are concerned in this table that we are going to talk about these two, subarachnoid and intracerebral hemorrhage. So we see here now, subarachnoid hemorrhage. Subarachnoid hemorrhage could be acute or could be chronic. So again, hypertension can cause the same bleed, but most probably whenever we talk about hypertension, we are going to think about intracerebral hemorrhage. So subarachnoid, I think you'll be getting as a picture based question. So if it's acute subarachnoid hemorrhage, you're going to look for normal contrast, non-contrast CT. If it is a chronic subarachnoid hemorrhage, gradient echo MRI. So this is how you're going to look. But how will you know that this patient is having subarachnoid hemorrhage? So something they should give you, they should give a clue that the patient is suffering from subarachnoid hemorrhage. Then only you can order for these tests. So the patient will come with something called thunderclap headache. Thunderclap headache, which means the worst headache he have ever had his life. He will try to even take away his life because of that headache. So the worst headache he's having in his life. A brain tumor, a space occupying lesion can produce such headache. A space occupying lesion can produce such headache, but there's going to be a projectile vomiting in that patient. Projectile vomiting. But this patient will be normal till then. But suddenly when he gets a thunderclap headache, this directly says it is a acute subarachnoid hemorrhage. Acute subarachnoid hemorrhage. So for those patients, you're going to go for a non-contrast CT. So I hope I'm very clear with this point.